it will be much easier to find out the artery. Whether it is open laparoscopy, I don't know, but robotic we have seen, we have done in Vedanta also, and we have gone to the artery first. Now regarding the thrombus first, I think so Inderveer Gill has described his technique robotically, and he has shown that it is better to do the thrombus first. The secret to this is that you have to take care of all the vascular control below the vena cava, below the thrombus in the vena cava, above the thrombus, and on laterally on the other side of the renal vein. And when you have all these controls available, then you can go for the thrombus first, including the lumbar veins also, you know.
Yes, sir. In fact, it is sometimes very tricky. What are collaterals which are essential, which you need to preserve, and what is going to, if you don't ligate, cause a lot of bleeding. So these are sometimes have to be decided on the table itself. Now, there is data of what I just spoke. Our fear about en-bloc pedicle control was that you might actually create a fistula in the long term. But there are many series, and I've just quoted one of them here, that if you do an en-bloc pedicle ligation or just staple it off, you are actually quite safe. You won't have a very difficult dissection there too. You can avoid all those problems. So we could think of a stapler to en-bloc tackle the pedicle. Yes, it depends on how thick is that pedicle. Are you able to get space above and below, and will you be able to clamp that entire thing at one go? So these are considerations which have to be individualized. Now, my next case is another one from Sanjay Sureka's unit. And here, this time, they've chosen to do CT. And as you can see now, in fact, you get as good, if not better, images. And here is the thrombus, which is just below the confluence. In fact, he's got about a 4 centimeter clearance from that point. Dr. Gupta, sir, specific to this now, I'd like to use these questions in this patient.
Can you go back and tell me the level of thrombus?
So, yes, it is below the hepatic vein confluence. We've got about 4 centimeters there.
Below the hepatic vein?
Yes, it's below the hepatic vein confluence. So you have this patient, large right-sided involvement, big thrombus, but you are spared level 3. Now, when do you consider looking at veno-venous bypass? Is this on table? Do you pre-op plan, as you were mentioning earlier? Now, suppose, in fact, this was a CT done 3 months prior to your surgery, and then you go in and you find there's infiltration. The hepatic vein has got infiltrated. It has gone up a little bit. How are you going to deal with that point? So the next 3, of course, I will also like you to address if you may. Now, you find that the IVC wall has tumor adherence, so this is involvement. There is a distal IVC thrombus which is there, which is a bland thrombus. How are you going to do all this, sir?
I will reverse the order to say that
yes.
Replacement of IVC filter. I think so this is becoming a normal practice nowadays.
Okay.
That we should put a IVC filter to prevent the thrombus migration. The distal IVC transaction,
so
yes.
If I may just stop you for 1 second. IVC filter thrombus, if there's a thrombus and you want to place that filter, how high would you be able to put that filter? Because if it is something which is covering the IVC and there is very little space between the upper level of that bland thrombus and the renal vein takeoff, the interventionist would not be probably very happy to put a thrombus, a filter at that level. So what kind of guideline do you go that, yes, at this level of thrombus, I need that filter?
At this level of thrombus, I think so, no. You can put a filter at a higher level in the superior vena cava also.
The guideline actually has been now established by the Mayo Clinic. They have a large series on this. If you have thrombus which is limited to the pelvic veins, you might be able to get your filter up and it helps. But when it is gone into the IVC, whether it is just below the renal vein confluence or even a centimeter or 2 centimeters above the IVC bifurcation, it's far better to transect it rather than try a placement of a filter. It's not easy to put, and then it actually doesn't help you much.
Can I say something?
Yeah, Jagdish.
Sir.
I'll tell you this, we used to do this putting the filter, but today the cardiac people say that there is no place for filter at all. Absolutely, there is no place for filter.
So here is what the guidelines out of Mayo, sir. This is what I was alluding to a short while back. So if you have space above the thrombus, which is clear, and there is some channel available, you can put a filter across. But anything more than that, like what we see here, it is safer to transect and ligate the IVC below that. The level of collateralization is very safe, and the risk of subsequently developing P in this patient is much lower if you simply transect that vein. I think this is something we need to be aware of. We need to follow it more carefully to avoid the complications postoperatively to this patient. Right. I have just 10 minutes, right. So I'll just wind up with this last case, which is a little bit of a diagnostic dilemma. So this is a 52-year-old male. He came with right flank pain long time ago, and he was actually diagnosed as PUJ obstruction. You might wonder, what am I talking about in this forum? Okay, so the guy in PUJ obstruction has been managed conservatively by his urologist, and he's found status quo for a number of years. So these are all his documents attesting to that this was stable renal function, so no surgery for that PUJ was done. Then, in about 10 years' time of follow-up, he now develops gross hematuria. There are no clots, cytology is negative, ultrasound CT is done. I'll leave this on for you to just see. And that's all that there is, nothing. The kidney is functioning okay, there is a little delayed excretion. Now, look at this. So, right. So the upper calyx, like Dr. Kulkarni pointed out, was distended, and there is a PUJ obstruction. So urologist has gone and done an RGP. He finds that the PCS is dilated on that side. The upper calyx is not seen, contrast is draining, but he doesn't find any source of bleeding with whatever he has done, and he goes and puts a stent. And then plans that I will do an endopilotomy for that PUJ obstruction. So this patient is not very convinced of what is happening. He comes to us for a second opinion. Saurabh, your patient, what would you think about?
Well, obviously, you're missing out on something here.
Yeah.
The first thing is, make sure, I'm sure my colleague, whoever has put a stent, has examined his bladder properly, because that's the easiest and, the source where you can miss it. Subsequent to that, I couldn't see very well on that CT image, but definitely the upper pole of there is something wrong there. I'm not sure. There's definitely cut off there. The collecting system seems to be a bit abnormal. So one of the the calyces looks abnormal there. So at the same, I would put a flexible ureteroscope and have a look and see what it looks like.
Okay, so that's exactly what happened. We went in with RIRS. It was difficult to see the PCS. There was active hematuria. We could see only the infundibular region of the upper calyx, and that I biopsied. Histopath, round cell. This is the actual report. Yes, on that small bit, no IHC was possible. But they asked for it. So I asked them, now what? So my point is, Sridhar, incomplete information, that is the evidence that we have. One biopsy, round cell tumor. Upper calyx, there's something which we cannot explain.
So round cell neoplasm, I'll consider doing a PET.
You want to do a PET, okay.
There could be any mets.
Right. And you want me to go again because my pathologist said go and do an RIRS again. I hesitated because I know the effort I have made to take that little bit, though like in all upper tract biopsies, it was not very helpful.
I'll try needle guide biopsy.
Okay. You will try a repeat needle biopsy?
Yes.
Needle biopsy, okay. So we did that PET and, well, it didn't help much, all right? So briefly what we had was this. 10 years, now upper calyx is dilated and RIRS not very helpful. I had a long talk with the patient and we decided that we treat it as upper tract TCC. all right? That round cell business, that pathologist which had given me, I actually disregarded at that time. And I told him that we'll go for an FRU, I'll open the kidney, have a look at it, and if required, I'll do a completion uretrectomy, and this is what was the plan, right? This is what came out. Sir? Yeah, okay. Now? Doesn't look like something we have seen very commonly. Something is amiss. Swapnil, what would you say? I mean, just guesses, basically, obviously, because this is not something we are very commonly seeing.
So there is a central scar to that, to some scar and a necrotic areas. It's not very clear
Yeah,
as of
something
now.
there, yes.
So round cell area is only two diagnoses, Ewing sarcoma or it is lymphoma, is either of them, or osteosarcoma of the small cell.
Absolutely. Anything else? Swapnil?
Not particularly. We'd like
Okay.
to look
Okay.
at the slide.
So this is
please.
what I got actually. You are absolutely right, and credits to your judgment. This came out to be peanut. So it was strange. I never expected it. This was a 52-year-old gentleman, peanut. So obviously, then the rest of the workup moved towards doing, the extra renal side. So we had a biopsy done for the bone marrow. It was negative. This is the Swapnil, would you like to actually just comment on these? These were the HNE and then the CD99 other markers. Would you like to comment on these, or?
So the PNET is the commonest round cell tumor of an adult kidney.
Oh,
So-
okay.
So among the round cell tumors, this is the commonest thing that happens. The closest differentials over here, we obviously rule out a lot of the other round cell tumors.
Okay.
Commonly RMS, we commonly rule out synovial sarcoma also, which sometimes can look similar to that.
Okay.
But PNET is quite a bit, there is no specific IHC for it. You know, MYC2 positivity, NKX 2.2 positivity, yes. But there are many other round cell tumors can give similar conditions.
Right.
So EWS-R1 gene rearrangement is usually very confirmative that this is, yes, indeed a PNET.
Right.
But having said that, 95% of these will turn out to be PNET. So, you know, so based on morphology alone, a PNET or even with a MYC2 which is confirmed to be there, it is good enough in most scenarios. You don't often go into the next steps.
Okay. Vinayak, this patient now, what next? So we have a histologically confirmed PNET. How do I manage him?
So the this is like almost like Ewing sarcoma. The main treatment is systemic therapy. So we usually give 17 cycles of chemotherapy alternating IE plus WAC. That's a treatment. And one modality of local therapy is done, so that should be good enough. Otherwise, usually we complement with radiation, especially if its margin is positive or something,
Okay.
or necrosis is not there. Otherwise, usually one modality is good enough.
So we have used actually what you suggested, 5 drugs. He received almost a year of adjuvant therapy.
17. Now we do every 2 weeks.
Okay.
It's not 1 year exactly.
Yeah.
17 cycles still we do.
Still do.
But it's every 2 weeks.
And then we also gave him some adjuvant RT to the,
Especially if it is violated.
Renal
The planes
fossa.
are violated. If
Right.
the excision time, if you violate the planes, you have to do. Otherwise, margin is clean and everything, you can skip the radiation.
Dr. Gupta sir, your comments, if any, on that?
I think so. You have to go back to that CT scan. You know.
Okay.
I don't know how the radiologists have missed that. If there was any, I had a doubt from the first time when I saw your CT scan. There's something is there in the upper pole.
Yeah.
And how, if suppose, see that solid area is also seen.
Yes.
That is cut off in the superior calyx actually.
Yes, sir, yes.
And that you see the upper one, that is the white area, which is the solid area.
Yes.
So I think so that was confused as a dilated calyx.
Correct.
But
sir.
that, I'm sure a good ultrasound will also tell it's a solid mass there, not a cystic or calyx, dilated calyx.
So you-
at that time, suspicion should have come that we
Right.
are dealing with a renal tumor.
You're right, sir. So one was the imaging dilemma. The second was the round cell report by the pathologist. Unfortunately, when you're doing a biopsy at the upper tract, it's not possible to give good amount of tissue and then for them to comment on the on a definitive biopsy. So these
No. The question is again, the pathologist will only tell you what you give him the tissue. And
Agreed.
sometimes you know, like in needle biopsy, the histopathology cannot be accurate. That's
Right.
why even in that cup biopsy you must have taken, or the person who has done that RIRS or endopolytomy.
Right.
So he has given a very small tissue.
Yeah.
So, and he already mentioned that round cell tumor can be PNET, so like that.
Yeah, so these are rare occurrences. Maybe some of our senior colleagues here have seen much more than me. Yeah,
Yeah,
yes,
we
please.
haven't, we have seen fair bit of weavings in renal, this thing.
Right.
Imaging is quite typical. It doesn't enhance much. And because of the atypical, they are also seen in very young people.
Right.
Usually. So because of those two things, not very enhancing and a young age, we have biopsied them before. And once you get the biopsy, on a renal biopsy, you can do all your markers and you can prove weavings. And then we would have given the chemo before because it quite well responds. And when we post chemo, we have gone and removed them. It all shows necrosis. So you are very happy that you had given the chemo
I agree.
before.
I agree. Santosh, your point is valid because these are patients where the non-enhancement, the younger age, a biopsy, all that helps you. What was a little untypical or atypical in my patient is this guy is presented at age 52. So this is not something that comes to your mind right off. So this was the point of bringing out a little rare case. I'll just switch all this to the last case, if I may. I have about a minute, so I mean straightforward diagnosis. Any one of our urologists can take this. Yeah, right? One, and this. Sridhar, what would you tell me? The diagnosis, forget it. We all know it's an AML. So what are you going to do with this, Ra?
Can I just go back to image, sir?
Yeah, yeah. Sure.
Huge AML. Okay.
Yeah, okay. Somebody just mentioned partial, okay. This big a tumor, you want to do partial, all right. Anyone else? Any other opinion? Gupta, sir? What would you tell us, sir?
No, I will discuss with the patient. If it
Yeah.
is a more than 4 centimeter size,
So
definitely
this
needs
was
a
in
treatment.
the region of 15
So
centimeters.
it needs a definite treatment.
Okay.
And if feasible,
Ah.
a partial nephrectomy should be the treatment.